Good evening, everyone. Thank you so much for joining us this evening. Before we get started, we wanted to go over a few housekeeping items for you. Please utilize the chat box for any questions you may have. We encourage attendees to interact and share comments or questions in the chat box while our panelists are presenting. Please note that this webinar is being recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Now, please take a moment to carefully review this notice. Both the recording and slides will be shared in an email following the event. A survey will also be included. The staff of the collaborative encourage you to please share your feedback as we plan future events.
Good evening and welcome to the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. I'm Michelle Durst, Director of Practice Management and Delivery Systems Policy for the American Psychiatric Association. As a member organization representative of the BHI Collaborative, I'm pleased to welcome you to our first of many webinars in 2021. This educational series is part of a suite of ongoing activities by the BHI Collaborative dedicated to equipping physicians with the necessary knowledge to sustain a whole person, integrated and equitable approach to physical, mental, and behavioral health care in their practice during the COVID-19 pandemic and beyond. These webinars are a collaborative product of 8 of the nation's leading physician organizations, established to catalyze effective and sustainable integration of behavioral and mental health care into physician practice. With an initial focus on primary care, the collaborative is committed to ensuring a professionally satisfying, sustainable physician practice experience and will act as a trusted partner to help them overcoming the obstacles that stand in the way of meeting their patients' mental and behavioral health needs. Today's webinar, titled Privacy and Security, Know the Rules for Communication of Behavioral Health Information, will give an overview of the current behavioral health privacy and security landscape, as well as real-world insights on how to safely integrate patient care while preserving patient privacy. At the end of tonight's discussion, we will have a Q&A with our experts to explore common issues or concerns that you may be experiencing. And without further ado, I'm pleased to introduce our speakers. Today's moderator is Lucy Hodder. Lucy is the Director of Health Law and Policy Programs at the University of New Hampshire, Franklin Pierce School of Law, and the Institute for Health Policy and Practice, and Professor of Law. Dr. Todd Peters is Vice President and Chief Medical Officer at Sheppard Pratt, and Dr. Robin Mater-Mast is the Chief of Staff at Gpmc Healthcare and the Medical Director of Care Transformation. And with that, I will turn the presentation over to Lucy.
Thank you so much to the organizers of this event and to all of you who have joined us for an evening conversation about privacy and security. What I'm going to do is give you a little bit of background on some of the changes in the rules and what they mean, and then talk with the real experts, Dr. Mater-Mast and Dr. Peters, about how to apply those rules in your own collaborative care or integrated care setting. Next slide. So I just want to let you know I am a true believer. I work at the Institute and the Law School, and we have just finished up a 3-year behavioral health integration program and also a 5-year behavioral health integration 1115 Medicaid transformation waiver. And so we have been absolutely in the middle of trying to support to address substance use and mental health, both really growing concerns everywhere and particularly in New Hampshire, to try and address collaborative care, enhance the sharing of information to support evidence-based care to the patient. So I get to talk to you a little bit about mythical barriers and then also pathways. There are pathways. You have to work sometimes to find them, but they are there if what you're trying to do is best for the patient and evidence-based. So what standards apply and what changes are underway so we can all know what's coming down the pike, and then what matters to practitioners providing integrated behavioral health. Next slide. I want to let you know that at the end of this presentation, there will be a time for question and answers so we can try and address what truly matters to you. So feel free to put them in the chat room and make sure we can address them. So just to be clear, coordinating care between clinically integrated providers is the goal of recent regulatory frameworks. So at the federal level, really they're trying to balance patient privacy against the needs for information sharing as part of a collaborative healthcare system. These are the stated goals of the recent proposed HIPAA regulations. They're the stated goals of the multiple recent changes to the substance use disorder treatment rules. And they are just a consistent effort at the regulatory level. They haven't made it easy, but it's still important to know that's the direction. Next slide. So I'm just going to remind everybody, I'm the lawyer, I get to do that kind of thing, just where all of our sort of privacy rules come from, because sometimes it all gets translated into a lot of confusion. But we have obviously HIPAA, the privacy rules and the security rules that are part of HIPAA protect individually identifiable health information. And so it's the information maintained by providers and payers, and there's still heightened protections for psychotherapy notes. And we'll talk a little bit about what you can do. And then 42 CFR Part 2. These are the federal rules that are overseen by SAMHSA that protect the confidentiality of substance abuse patient records. And they protect it from disclosures without express patient consent. Now, for many years, providers just didn't worry about 42 CFR Part 2, and now we're talking about it all the time. Well, that's because before the Affordable Care Act, there really was not pervasive coverage of substance use disorder benefit. And the Affordable Care Act required that benefit to be covered as part of the essential health services. And so plans included the benefit. Providers of all kinds began making sure they had that service available. And then 42 CFR Part 2 became something we all talked about. FERPA protects education records. Right now with school nurses doing a lot and really wanting to communicate with you and communicate with pediatricians and becoming Medicaid providers. FERPA that protects education records is also an important source of privacy rights. Then, of course, there's state laws, the privacy of medical records in your own ethical guidelines and your ethical rules. Special rules for minors. Minors can consent at much younger ages to get treatment for substance use and usually sexually transmitted diseases. Privacy of mental health records. Oftentimes that the state law requires an actual written authorization. Privacy of substance use treatment records, also a source of state regulation in rules, ethical rules, and other professional conduct rules. Some even incorporate 42 CFR. Our MLADACs and LADACs incorporate 42 CFR right into their licensing standards. And then there's special rules oftentimes for patients in acute mental health distress. So patients who are involuntarily admitted, et cetera, or being treated for emergency circumstances, those also are a source of privacy rules. Now, remember, some of you may work in hospital settings, in teaching hospital settings, or in health clinics, or other areas that have federal funding or state funding. Oftentimes your grant funding is also a source of privacy rules, so make sure you check those. Next slide. So I want to make sure you know that what the themes are coming out of the federal regulatory framework right now. As I said, it's very supportive of collaborative care. So the right to access was an initiative announced in 2019. There's been a real push to make sure patients have the information that is driving their treatment. So patient access to information is a real focus of federal regulatory push. There was another change, a proposed privacy rule from OCR regarding HIPAA that actually is trying to allow for enhanced sharing for care coordination and care management. So those comments can be submitted. We'll see where that goes. There's the interoperability and information blocking rule that is effective April 5th, 2021, that really requires healthcare providers to give patients access to their electronic health records. So you're seeing the theme here, patient access and transparency. The final anti-kickback and Stark rules, not privacy, but still important for everyone to remember because they have a lot more power than physicians think. And then they butt up against it and they're like, wow, the anti-kickback, I didn't know it required that or prohibited that. So enhanced alternative payment models is a real focus of the anti-kickback and Stark changes, trying to support things like integrated behavioral health and the sharing of savings from those models and the ability to be a little bit more fluid with where the dollars flow. Next slide. So as a HIPAA provider, you know this, right? You can share information, protected health information for treatment, payment, and healthcare operations. You can do that without consent. Yes, your patients need a privacy notice, but you can share that information without a consent. Mental health information is treated the same as health information. The one thing to remember is that psychotherapy notes are specially protected still. So healthcare providers can disclose to other healthcare providers protected health information contained in the medical record about treatment, case management, and coordination of care. Next slide. And remember also that HIPAA is a little bit more forgiving than many providers think around patients in substance use crisis. So there is the ability to share with family and close friends who are involved in the care of the patient if the provider determines that it's in the best interest of an incapacitated or unconscious patient, and it's directly to the family or friends who are there. So in an overdose situation is really a critical piece where that comes to play. Next slide. So I'm just going to go through the basics of how these two regulatory frameworks are different. As I said, HIPAA applies to protected health information, and there is the ability to disclose without a patient consent. 42 CFR is very different. It only applies to substance use treatment records created by a substance use treatment provider. Now, you may get them and have to specially protect them, but they're likely not your records if you're a primary care and you aren't a substance use treatment provider and hold yourself out as one to the world. So 42 CFR protects the substance use treatment records, and it does not allow for any disclosure of even the identity of the patient without a patient consent, written patient consent, okay? There are other exceptions, but that's the primary difference. It even requires patient consent to disclose for payment. Next slide. So first thing you got to ask yourself, are you a Part 2 program? So are you a provider whereby the substance use treatment records you create are specially protected by 42 CFR Part 2? Are you an individual or are you part of a unit in a facility that holds yourself out as providing, and in fact, you do provide substance use treatment, diagnosis, or referral? So that's the fundamental question. If you are that, then your records are probably especially protected for your substance use clients. If you're not, then they're not. Next slide. So once you've determined whether a substantial part of what you do is substance use treatment and you hold yourself out as doing that, once you decide whether you're a Part 2 program, you need to remember notice of privacy rights is special under Part 2, compliant consent forms are special under Part 2, non-redisclosure notices have to be provided, those are special under Part 2, and then you have to add special language to your business associate agreements. Next slide. So just ask yourself a couple of these questions. Primary care providers who work in integrated settings are likely not Part 2 providers. Talk to your team, figure out who you are, okay? But not all primary care providers who prescribe MAT are a Part 2 program. Only if you hold yourself out and it's a substantial part of your practice. You can in fact do, and members of your team can engage in SBIRT, screening, brief intervention, and referral to treatment, and still not be a Part 2 provider. Okay, so just be really careful you figure out who you are and who the people in your team and on your integrated team are before you worry about 42 CFR Part 2. Next slide. COVID emergency has given flexibility to practices under both privacy regulations. HIPAA, there was an OCR announcement that they'll waive penalties for HIPAA violations arising out of good faith use of telehealth. You probably know that. Broad use of telehealth modalities, and providers don't need to have a BAA in place with their technology providers. So really important to know that that's under the state of emergency, the federal state of emergency right now, which we understand has just been continued and may be continuing for a long time is what I'm hearing. 42 CFR, not quite so helpful. There was not a waiver of any of the 42 CFR rules, but SAMHSA did say, hey, there is an exception, an emergency exception under 42 CFR, and providers can determine whether or not there is such an emergency because of COVID. Okay, so there is a telehealth exception as a result. Next slide. So guidance for integrated practices. Privacy rules are drafted to encourage information sharing, to support care management and care coordination. Remember that while it seems like they're tough and the lawyers can be tough about it, the privacy rules have pathways for you to engage in evidence-based care for your team, amongst your team and for your patients. What they don't allow is disclosures that are going to result in stigma. And we know that stigma remains a very large problem around mental health and substance use. You may not see it being involved in these integrated practices, but it is there. You know from your colleagues, you know from the community, the stigma is there, and that's why these privacy rules exist. So that's part of your ethical dilemma, which is doing what's best for the patient, sharing what's needed, but remembering that you are the holder of information that could result in stigma and in fact impact the care your patient receives. HIPAA allows for sharing for payment, treatment, and healthcare operations. Treatment records by primary care physicians, not a Part 2 provider, based on your own patient encounters are explicitly not covered by Part 2 under the new rules that were passed and are in effect August of this year. Even if you occasionally prescribe medically assisted treatment, okay? I added information about the new Part 2 rules in the appendix. You can review that online. It will be shared with you. The consents have become a little easier and communication with other providers have become a little easier. But integrated behavioral health teams may share treatment information about their patient and disclose information for administrative purposes. So the team can share the information. Electronic health records are really being pressed by the federal rules now to be able to accommodate special protections that your patients want of their private mental health or substance use treatment records. So remember that they are supposed to be Part 2 compliant, and you should press your electronic health record system to try and figure out what works best for your patients and your practice. Next slide. So I'm going to leave you with the physicians who are going to talk about their experience. But one of the most important things with your team as you're trying to navigate what you can or can't share in your either collaborative care or fully integrated setting is think about your patient flow. Okay, where does your patient need to go? Where does that information need to go for the best evidence-based care for that patient? What do you want to be able to share, and with whom, and when, and why? And then it's very, it really helps your compliance folks create a pathway to support your integrated care if you work on it as a team to develop those pathways based on what you really need to do. Don't throw up your hands and say, privacy won't let me do anything. Sit down and figure out what is it that you need to share, with whom and why, and there's a pathway to get there. So I'm going to leave you with that and be available for questions. And I see that there's a question in the chat, which I can answer along the way, which is whether health insurance, Medicaid, Medicare claim information is subject to Part 2. It depends. If it's created by a Part 2 provider, that information can't be disclosed to the payer without a patient consent. But once it gets to the payer, they are allowed to engage in a lot of audit and evaluation without patient consent. So I'll talk more about that during the Q&A. So I'm going to turn it over right now to Dr. Is it Mater Mast who is going to be talking next? So I'm going to turn off my camera right now and turn it over to Dr. Mater Mast and Dr. Peters.
Thank you. I am happy to be here tonight. My name is Robin Mater Mast, and I apologize that you can't see my beautiful smiling face this evening, but we are having technical difficulties on my side of the camera. So please bear with me as we move through these slides and we share the information this evening. So we are going to be talking, Dr. Peters and myself, about the integrated behavioral health program that we created between our two organizations and our primary care practices. Next slide. So we do have an integrated care model. This model started in 2016 as part of a grant, a state grant through the Hospital Association of Maryland. And it gave us some funding to try to incorporate behavioral health, substance abuse into our primary care practices. So we took that money and we've done a lot of work over the last 4 years, and we made some changes over the last 6 months, which we're excited to share with you this evening. Next slide. So Gpmc healthcare system, as you can see on this slide, the red dot in the slide is our hospital. We are a one hospital system. We do have a large hospice that we are associated with skilled nursing facility programs, elder medical care at home programs, and we also then have an employed physician group. And this behavioral health integrated program really has been founded in the primary care practices. We have 12 of those primary care practices, one complex care clinic, homebound patient practices, and then we also participate in a program called the Maryland Primary Care Program. And we have independent aligned physicians that are working with us in this program, and we help to manage their cost and quality. And we are able to offer some of these resources to these aligned independent physicians as well. We're serving approximately 8,000 lives in these primary care practices across the greater Baltimore region. Next slide.
And again, I'm Todd Peters. I'm our Chief Medical Officer and Chief Medical Information Officer here at Shepherd Pratt. And in kind of a comparison slide, I wanted to show the locations of many of our 387 sites of service that we have all throughout the state. As you can see, we have a lot of care locations very proximal to GBMC. We actually, our hospitals share campuses here, and so we are physically close to each other, along with which has helped to facilitate this partnership that we have in a collaborative care way, but also working together on a regular basis. On the next slide, I can tell you a little bit more about Shepherd Pratt and the reach. We are the #1 and largest provider of nonprofit behavioral health and psychiatric services in the nation. So we touch about 70,000 discrete lives a year. So that's when I say #1, we are have touched the most behavioral health lives per year across all of those different sites that I told you about before. Our reach is, on a yearly basis, we serve patients all from around the country and from even around the world. We also are the largest provider of non-public special education programming in Maryland, and are really proud that over the last several decades have been ranked in the top 10 in the US News and World Report. This year we were ranked #5. So we're really proud of our programming here and a lot of the partnerships that we've been able to create across the state. So on the next slide, you can see a little bit of the depth and breadth of what we do. I won't go into all of this detail. It's a small it's a shorter presentation today, but really, for all purposes, we really do pretty much anything and everything within the behavioral health arena across the state, and really do try to think long and hard about how we can help all folks in need. And we really, a large percentage of our population come in through Medicaid and Medicare services. And we're really able to do a lot of vocational services and other sorts of things. We have about 1,000 individuals living in residential programs throughout the state as well. So that's a little bit about Shepherd Pratt. On the next slide, I wanted to just talk a little bit more about collaborative care. I know that there are many different presentations that you can have on what is collaborative care and what does it mean, but we can talk a little bit about what it means to Robin and I within our organizations, and kind of just a couple of slides giving an overview of that. So the real goal behind collaborative care is to recognize, I think, a couple of things. One, that patients often have behavioral health and medical issues comorbidly. A lot of times their mental health issues may be undiagnosed or underdiagnosed. And we know that undiagnosed and underdiagnosed behavioral health issues leads to an impact in the cost of care model. So on the next slide, we'll talk a little bit more about why this matters and why these programs work. So we know that behavioral health issues are a major driver of health utilization and cost. It's a major driver of absenteeism and really presenteeism, or really just not being able to function even while at work or at home or in school or other places. We know that effective treatments do exist, but lots of people don't get that, and lots of people don't really have access to the type of care that works. We know that there's a real shortage of psychiatrists. I myself am a child and adolescent psychiatrist. There's an even larger shortage of us, and no matter what we do, we're really not going to overcome that gap in the next couple of years. So we need to think thoughtfully about how we all work together as one large team to create this integration that will allow for better access to care, better health outcomes, lower costs. We really need to think about the specialist seeing the more specialized patients, and all of us working together as a team to collaborate on those that can be maintained and treated safely in primary care practices. And Robin and I talk about this a lot. The reality is the majority of people with behavioral health issues will first show up at their primary care offices. So what better place to make the diagnosis, use screening tools, and to be able to even start treatment, which may in itself be enough for that patient and hopefully will not require more intensive level of services. So you can see here the triple aim is to improve patient care, reduce costs, and improve the health of patient populations. On the next slide, we'll dive into a little bit more detail around how that works in practice. So if you could advance the slide. So, again, what we're really looking at is how do we overcome barriers to getting people treated in a timely fashion? Because we know that sometimes people languish on wait lists for weeks and months to try to see behavioral health providers. And we want people to not have any sort of bad outcomes while waiting for treatment. So we want to help address those patient outcomes. So we know that timing is key, just like anything in medicine. And so the earlier we can intervene, the better the outcomes are. We want to create less frustration, which in itself can sometimes exacerbate people's mental health issues for not getting treatment and the frustration they're in. And develop this collaboration that really works, and hopefully will lead to not only just better patient satisfaction, but also provider satisfaction as well. So on the next slide, we'll talk a little bit about how this looks and works. And then Robin will go into much more detail about how things work with our organizational partnership. So typically when we think of the collaborative care team, we think about the patient, obviously, as the most important member of that team. We then think about the treating practitioner, which typically is the billing practitioner in the true collaborative care model. So this can be a physician or a NP or a PA that is typically in primary care, but may meet one of the other sort of primary care medicine specialties that, oncology clinics, cardiology, et cetera. There's also a behavioral health manager, care manager, which can be a co-located individual or sometimes be an individual that's outside of the practice but affiliated with the organization, and really is doing a lot from a population health standpoint to oversee folks that, at a population level that may be screening positive for concerning signs of depression or anxiety or other sorts of things through things like the PHQ-9 or whatever other rating scales one may be using. And the goal then is to then work with the billing practitioner and work within the clinics to help to identify those needs, and doing some interventions with the practitioner and also with the patients to get them the care that they need in a timely fashion. Psychiatrists also, or even nurse practitioners, psychiatric nurse practitioners can then also serve as then the consultants, which are folks that are able to, potentially be able to help the behavioral health care manager to monitor these populations, and also help to triage and determine who could benefit from different levels of care at different times. So I'll turn things over to Robin to further talk a little bit more about our collaborative care arrangement.
Thank you, Dr. Peters. One of the reasons that we became interested at GBMC and participating in this type of program, it's multiple reasons why, but one was that we were an accountable care organization in the state of Maryland, and we were really focused on utilization and reducing total cost of care. So when this grant became available, it was something that we really knew that we needed to focus on. And as a family medicine physician who practices still seeing patients, I really understand how frustrating it is, not only for myself as a practitioner, but for my patients when they have a need, a psychiatric need. Often they have struggled so much just to find the care that they need that it's bubbled up to a point of almost urgency and emergency for these patients and these families. So anything that we could do to help to smooth out that referral process for these patients was something that was very welcomed in all of our primary care practices. And there has been a great business and clinical case for this. So on this slide, you can see the cost burdens from unrecognized, undiagnosed mental health cases. So the cost can almost increase by $400 per member per month for certain diagnoses. That's almost 100% increase for the diagnoses that you see in the slide, like arthritis, asthma, and hypertension. Without the use of routine screenings in a patient's provider's practice, 70 to 90% of the expected patients with depression or anxiety can be missed. If you add substance abuse to this as well, you will see that the cost can increase by almost 200%. And if you have mental health and substance abuse present, costs can increase by 10 times compared to a patient without those comorbid conditions. Next slide, please. I'd like to just share with you a little bit about the collaborative care model that Dr. Peters was referencing when he described the team. This really was pretty simple to implement from the primary care perspective. It is billing from the primary care medical side of things. It is capturing all direct and indirect provider care. This is very similar to the chronic care management codes that were released by CMS back in 2019. So these are codes that you can use that capture not only the time spent with the patient, the time in conversation with a primary care provider, and the time with a psychiatrist. So it's really nice to have that all-encompassed code. And the requirements for submitting those codes really can be done as long as you have a few things in place. So you need to have your behavioral health integrated care team in place. That can mean that you have a primary care provider, could be a nurse practitioner, a PA, a behavioral health care manager. Sometimes it's present, but not always necessary. And you need to have a behavioral health counselor that is there to provide those services for the patient. This is really great. It's a team-based approach, and you want to have a registry to help that team function. So you need to know who are the patients that you've seen, who are you calling next, what are their screening scores that you're working through, really trying to improve those scores and communicate with the entire team about what the next steps are to get to the patient to the level of clinical care and outcomes that you're hoping for them. The documentation for billing is relatively simple. You just have to account for the time in the medical record, supplying the minutes per month with the correct code. There is a code for the first consultation, and then there's a code for the amount of minutes up to 60. And then if you go over that, then there's another code that you can supply for that month as well. And within the chart, whether it's electronic medical record or paper, you need to have evidence of the core components of care elements. The reports, the conversations back and forth with the providers, the documentation of the amount of time. So those things all need to be present. When we started this program, we didn't have behavioral health consultants in our primary care practices. We had to go out and find them. So we started with an RFP, and of course we were so lucky to have Shepherd Pratt be our neighbor, and they came to our rescue and helped us develop this program. They actually supply our behavioral health care managers and psychiatrists. So we pay them through a subcontracting type contract, and they are able to help manage those people, as well as find them, hire them, and help us along with that process. Next slide, please. So consent. I don't want to say, I know the slide says no separate consent needed. And that really is true. I think you heard Lucy say that as long as you're following the HIPAA rules and regulations, and you're not including psychotherapy notes, and you stick to kind of bread and butter in primary care with diagnosis, treatment, that you are able to share that information. But one of the things in primary care is that you really value your relationship with your patients. So you would never want them to feel like you were compromising their security or their privacy. So although you don't have to have a consent that tells them that you are sharing this information with other healthcare providers, we do try to have that information. So on the annual consent to treat agreement, you may put a statement on there that we have the right to share your information with other healthcare providers. Really, the consent that is needed for collaborative care has to do with the billing for the collaborative care program. So the patients need to understand, again, that they are entering into a program that has a bill that's associated with it. And this is a bill that's totally different. They've never received a bill in primary care for these integrative services. They're not used to it. They didn't see it coming. They're not expecting it. So you do need to document that. And there's lots of ways of doing it. You could do it through a phone conversation and document it in your medical record. We even send out my chart messages to patients once we've identified them as somebody maybe who we would like to engage in the behavioral health program. So you can just send the verbiage out explaining what the program is, and it implies consent. We actually ask them if they do not want to be contacted by our behavioral health consultants, that they should give us a call and we will opt them out of the program. We make sure that they know that the psychiatrist will send a report and treatment recommendations to the primary care provider and the behavioral health care manager. These treatment plans are gauged for the patients to try to make sure that they get the best care plan for them. The behavioral health care manager can also provide support and perform repeated assessments, make sure that the patient is improving. We want them to know that there is a goal and we're trying to work towards that goal together. And we also then make sure that we include that there is patient financial responsibility, and that we have a behavioral health care manager who will go through the details of billing, as well as answer any questions that they have about the program at their first visit with the behavioral health care manager. Once we see patients face to face and we have these conversations in primary care physicians do not like to have conversations about how much money things are going to cost, or, we usually don't say we're going to give you an EKG, but that's going to be a bill on your insurance, and I'm not sure if it's going to cover it or not. And this is how much it usually costs. So we are a little avoidant on having those conversations, but we do make sure that we enter in to these conversations, just explaining that this is a separate program. We have a relationship with Shepherd Pratt. The behavioral health care managers are on our team, and that there will be some type of financial responsibility for the patients. If you could go to the next slide, please. This program has really improved communication between providers about mental health and substance abuse. So the behavioral health information is located in our medical record for only providers to see across our current hospital system. I think you heard Lucy mention you can develop care pathways to look however you want it to look. And as a primary care provider, I know how important it is to have a problem list that is up to date and includes things like depression or anxiety. But I also know that we don't want to share psychotherapy notes in our EMR. And it is really important, especially in healthcare systems like mine, where you have your insurance and you receive a majority of your healthcare from your own healthcare system. These things are private and you want to keep them private. So our hospital made a decision that we were going to keep these notes in what we call a sensitive function. So we actually mark the notes sensitive so that the only people that can see it are the other providers across the healthcare system. So if I'm treating my patient for anxiety and they show up in the emergency room, that emergency room physician will also see on that patient's problem list that they have anxiety and that they are potentially participating in the behavioral health program. Substance abuse issues, we had worked through earlier in our program. We actually had a substance use consultant who we were able to tag and see patients once they were identified. And that was really wonderful to have that. But we did feel like it was difficult to the degree that we wanted to share information. And again, since our patients are often employees in our healthcare system, we really felt that we wanted to protect these patients' security and privacy. So what we did was make available, of course, you can make a referral to substance abuse from a primary care provider. You can do that and you can see that a referral was made in the EMR. We also then asked if the substance use consultant would provide us with messages back saying that the patient showed up for their appointment and was under treatment, or that the patient didn't show up and they've reached out to them a couple times and they just wanted to let us know. So those type of things really helped us to kind of close the loop when we're dealing with these patients that are really struggling with a variety of issues in addition to substance abuse often. The emergency room often sees patients for substance abuse as well. And they had developed a expert program with a peer-to-peer recovery coach option. And we found that we were operating in silos despite being in the same electronic medical record. And early on, we had built that electronic medical record to protect the patient and give them privacy. But we quickly realized that this was actually impeding care, and then we had people doing, double the work and not communicating. So we made sure that the ER could see what we were doing and that we could see what the ER was doing as far as the peer-to-peer recovery programs and the referrals were concerned. We also have a wonderful health information exchange system here in the state of Maryland. It is called CRISP. And this is another opportunity to share information across the state when patients have one of these issues. But I would counsel you to make sure that you are very careful about the information that you're shared. Again, we want to protect our patients' privacies and security. But at the same time, we need to communicate with each other as providers to allow people to really know what the root cause of the patient's issue might be. So an example of this would potentially be a patient who shows up for abdominal pain and has had 20 CAT scans. We've actually had patients that have had 100 and have showed up. So that type of patient, it would be wonderful to say something about if a patient shows up for abdominal pain, patient is engaged in a behavioral health integrated program, and here's the number of the care manager to call. So these are the type of information that we're really trying to share across the healthcare system to provide a better patient outcomes. The only specific information, again, that you really should be sharing is the participation in the program, the notes with diagnosis and recommended treatments, maybe the frequency of the treatment that was furnished, notes with results of the functional status or the results of the screening that have been occurring within the program, so you can see how these patients are really progressing with the treatment plan. But we do not want to know any of the psychotherapy details. We do not want that documented in the medical record. And so when you're working with a behavioral health care manager, it's really coaching them up about the type of information that they should be documenting and getting them to document that more like a primary care provider would than they would doing their typical psychotherapy notes. Next slide talks about some barriers. So we are working with lawyers, and I apologize, Lucy, that this can be challenging and very difficult. But I'll tell you that they will be your best friends. It's just such a changing landscape. You have to hang in there with them and continue to encourage them and remind them, be persistent, this can be done. Decisions about break the glass versus sensitive information than EMR, those are different levels. If you do a break the glass, that means a report actually gets generated. You have to enter information about why you needed to see that information. That is an option if you're really worried about security. And the landscape is changing, as has been mentioned, with the Cures Act. It's coming out soon, and patients are going to be able to see this information as well. We've had some patients that don't fit the model in collaborative care. They have more severe mental illness than they need, so collaborative care is not for everyone. And we have created an access center with Dr. Peters' leadership to make sure that those patients find a place to get cared for as well. You need to market this model to the community because it is new and different. And I want to tell you that most insurances are paying for this, and it's great. If you go to the next slide, it shows that almost all the insurance companies that we deal with here in the state of Maryland are paying. We've had no substantial denials. Medical assistance is a barrier for us, but that is in the state of Maryland. I've heard other states that have worked through this just fine. The next slide talks about the work queue. I know we are getting short on time here, so I am going to just leave this information about how we help to manage working through collaborative care with the universal work queue, and the next slide for productivity since launch of our program. If you have any questions about that, I would be happy to answer that later, or you can email later with questions. The next slide shows the results of this program, and I just want to quickly highlight that it has been very successful. 48% have reduced their PHQ-9 scores, while 59% have reduced their anxiety GAD scores. And the most important thing I feel on this slide is, if this program was not available through your primary care office, how likely is it that you would have seen a therapist elsewhere? 39% of people said that they would have sought care elsewhere. So there's a big chunk that would have not. That leaves a lot of untreated mental health out there. If you go to the next slide, it really just shows the people doing the work are very happy with this program as well. Providers were surveyed, and you can see the results on the right side. They were very happy with the information. The lowest score has to do with the use of the psychiatric medications. So the psychiatrist makes recommendations for the primary care to do the prescribing, and some primary cares are comfortable with that and some are not, which is why you see that number a little bit lower than the others. And then lastly, what can you implement today? On the next slide. So you could formulate a relationship with a group offering COCM or hire your own care team to start this type of, you can get a consultant as well to help you to start this in your own primary care practice. You could check with your state to see if they have any recommended programs or partners for behavioral health integration. And then AIMS Financial Modeling has office hours. You could go to the AIMS website and you can find out more. And then, of course, you can learn more from resources like the event that you're participating in tonight that is provided by the Behavioral Health Integrative Collaborative model and the American Medical Association. So I'm sorry I talked really fast at the end, but I want to give you all time to ask any questions that you may have. And thank you very much for the opportunity to speak with you this evening.
Thanks so much. What an amazing presentation. And I think we're going to be taking the questions as they come in the chat, or if, so please share them with us so we can make sure your questions are answered. What an incredible story about your collaborative care model. And I know, Maryland has so much going for it that we're envious of, but this is quite an incredible success story. Tell us a little bit about how your model may or may not manage adolescents. or younger children receiving behavioral health, mental health, and substance use care, and how you may change your processes or pathways with children.
Dr. Peters?
Yeah, so I think to date, a lot of we are actually just really kind of embarking on more of a overlay and working arrangement around pediatric patients. I think that the main focus has typically been around the adult care. I will say though that I definitely have helped to run pediatric collaborative care programs elsewhere. And I have the good fortune of being on the Healthcare Access and Economics Committee for the American Academy of Child and Adolescent Psychiatry for the last 10+ years. And there really we have a lot of wonderful experts on collaborative care models that are part of that committee, and have had the chance to work with a lot of other folks that have built them. So like, I think of like Barry Servette and the MCPAP model up in Massachusetts. And when I was down at Vanderbilt, we helped to build a pediatric collaborative care arrangement within the health affiliated network there. So I will say, actually, you know, the model itself can mimic very closely the model that Robin spoke to today. You know, really, again, it's about having it's about doing the age appropriate screening questionnaires. It's about identifying and creating infrastructure that allows the pediatric patients to answer open and honestly around the screening questions, and kind of creating that infrastructure there, since they may have a parent looking over their shoulder or other such things. I think it's making sure that you do have child and adolescent behavioral health providers that are integrated within the clinics too, because again, things just look differently with kids than they do with adults. But at its core, a lot of the infrastructure is really the same. And sometimes the biggest barrier can be just because of the lack of child and adolescent behavioral health providers, that care network, when somebody does need more than just what can be done in the practice. And I think that's really where certain states have shown that, where, you know, and left ahead of others, where they have that statewide integrated program that then has a statewide network of providers that can be escalated and called upon when folks need it. So those are ones that come to mind.
Thank you for that. And I presume that you're able to manage their consents and deal with the parents around those changing age limits and permissive age limits in your state.
Yeah, and that's, you alluded to it earlier in one of your slides, where that is a big take home that I would say to you all listening, is that it is really important to understand and to think about, you know, knowing the age of consent within your state, and understanding what is permissible as far as being able to provide any type of care, let alone mental health care for certain ages and certain individuals. So having that, and kind of, it's going to become even a bigger task as we do move further into the Cures Act mandates and around the patient portal and access, and who actually gets access for that child's record. These are definitely things to be thinking about and be thoughtful about at your own organizations.
Dr. Modermast, anything to add to that conversation around the critically important issue of treating adolescents? And I'm going to add on to that question, have you all integrated peer supports into your program? And if so, how have you done that?
So for the pediatrics, we absolutely screen our pediatric patient population 12 and above. And then if something happens to come up with a patient visit, we've been very blessed to have some of Dr. Peters' staff who are equipped to deal with pediatric patients. So that's been wonderful. I'm sorry, the second question was?
Have you been able to incorporate peer supports as one of your closed loop referral options or within your integrated practice?
So we did do peer support with our substance abuse program. we did peer recovery coaches. So we have past addicts that work in the emergency room. And when someone comes in and is identified as having a substance abuse issue, those peer coaches are tagged to go in and work with the patient and then actually continue to follow up with them once they're discharged if the patient would like that.
Great. So I want to ask you a little bit. You rattled through a whole lot of issues that involve technology, and I know with the CARES Act and the additional CARES Act coming down the pike, we have all kinds of changes around interoperability and patient notification and transparency and price transparency and medical records security that include access, just a whole lot that's going on. And I guess what my question to you as primary care providers going 90 miles an hour trying to manage your patients and get to them what they need and get them to where they want to go, how did you deal as a team, both internally and externally, with the various administrative and compliance folks around the technology fixes you needed to accommodate your collaborative care practice and the privacy expectations that your patients might have?
Robin, would you want to go first?
Sure. We had a lot of meetings. That's what we did. A lot of meetings, a lot of conversations with lawyers, a lot of changing of consent forms, figuring out what exactly we wanted to be protected and protected from who. So as a primary care physician, I really believe that if you don't have all the information about a patient, that you're only treating part of them. So it is necessary to have an up-to-date problem list to give the patient the accurate, correct type of treatment. So just encouraging people to make sure that problem list is up to date. And then if there are diagnoses on that problem list that will create problems for patients, are they going to leave? And is somebody going to say something that they're going to see their after visit summary and make some type of judgment about? Are there things that are really kind of personal and private? Maybe the patient asks you not to document it or not to share that information. So there are tools within our EMR to not share information with the patients. And that would we really use that when it's going to cause some type of either mental or physical harm for the patient.
I think the thing you mentioned there, which I'll highlight with it, Lucy, is time and how to have the conversations that you need to have during short visits. The reality is, I think talking about what is documented and where it's documented is an integral part to medical care, and it doesn't get enough airtime in visits. What I've personally found is carving out some time to talk about what I'm going to be putting into one's chart and where that goes and who sees it really helps to build that patient and doctor alliance. It helps to, I have very candid conversations with individuals about very heavy topics, as we all do in medicine, but really talking with them about what diagnosis I'm putting in and what that means and who will see it and other sorts of things. It takes some extra time, but what I find, and this goes back to that stigma piece that you talked about before, I'm a little bit, I am actually on the side of fully open and transparent notes and treating behavioral health just like you would any other part of medicine. I truly believe that we actually perpetuate the stigmatization of mental health issues by treating it separately. And it's hard because I recognize that some people want privacy. I think the place that I've found is we let the individual decide for themselves if they want to have their chart be sensitive or private and work on that at a patient level, but do more as organizations. And again, I'm saying this as a chief medical officer or chief medical information officer and somebody that deals with this IT stuff a lot. I think the organizations that have better been able to integrate their behavioral health notes and allowing behavioral health providers to share the same med lists, problem lists, what have you, end up feeling much more satisfied around being able to be transparent around behavioral health care. And I'll tell you, in today's day and age, the majority of times patients are upset if they find that people can't see what other people are charting. And as long as you're being transparent about it, talking about it, having a conversation, most people are truly okay with it. I can say that with confidence, having been in an organization where we did open it up and we did not create any sort of break the glass or note sensitivity around those non 42 CFR Part 2 providers, and really just said, we're going to be doing the same shared list for everything. So I encourage everyone to kind of think about their own organization, what they're doing there, and how that mental health interplay fits in. Because again, the 21st Century Cures Act is forcing our hand. You know, that psychotherapy note provision really talks about psychotherapy process notes, and the majority of people aren't doing those. And so the reality is, this is really going to open up a open notes approach that is going to put these records out to people in fairly near real time, and people will be seeing these through patient portals and that sort of thing. So it's a good conversation to start and to have, and to know how your organizations are going to be handling this, because it's definitely coming.
Thank you so much. This is Michelle again, and it's such a good discussion that I hate to jump in, but we are at the end of our time for today's discussion. And before adjourning, we, the BHI Collaborative, would be most appreciative if you could provide your valuable feedback in our short event survey, which can be found in the Zoom chat and will also be sent around via email. Your feedback will help to inform future educational sessions and resource development. Our next webinar, launching in February, will be covering behavioral health integration in small practices. Please stay tuned for more details. Also, if you were unable to attend the previous webinars in this series, check out the Behavioral Health Integration Overcoming Obstacles webpage on the AMA website and the playlist on the AMA's YouTube channel. Thank you again to our fantastic speakers for tonight's presentation and your valuable insights. And to all of you for joining us live, please enjoy the rest of your evening.
Thank you.
Thank you so much.
Thank you.